And the benefit of this technology, obviously, is once you have the ability to reposition it and resheath, it will allow you to improve implant depth. And I think by changing the implant depth, you will improve power valve leak. It certainly gives you a reassurance, a safety net, if you say, or a seat belt that allows you to have multiple goes to getting it right. And that has ultimately allowed this technology to have a very, very predictable outcome. And the depth is important. So if you go between 1 to 3, your pacemaker rate is significantly reduced compared to going to, say, 3 to 5 or 6 to 10. Although the device does have a safety mechanism. So in terms of steps, I'm going to skip through this very quickly. You cross the valve, obviously, using whatever techniques you like. But once you have crossed the valve, I would recommend putting a pigtail in first, and then using the pigtail to position any of these stiff wires that you see here, either a pre-shaped wire, or a stiffer wire, or shape your wire yourself. But shaping the wire, a shaped wire, is the safest way to make sure that you protect the free wall from perforations. Once you've done that, you check, and you do all this in the RAO view. You check to make sure the wire is comfortable, and your second operator is also comfortable with controlling the wire. I think for TAVI, there's 2 areas where if something goes wrong, you really can't control very much. If you have an annular rupture or you have an LV perforation, these 2 catastrophic events, there's very little you can do. Only a surgeon can deal with it. And even in experience center, with a surgeon in the room, pump in the room, anesthetists in the room, the outcome for those 2 events is really catastrophic. So you really want to make sure you can avoid that. And it's a very easy way to avoid it. You just make sure this wire is under control. You make sure you size your wire properly, but make sure the wire doesn't go too far forward. And the second operator is key at this point. I'm going to talk very briefly about this. The Evolut Pro device at the moment, Evolut R as well, you have to check to make sure the valve is fully loaded before you take it into the patient. And therefore, it's important before, I tend to do this even before positioning the super stiff wire or stiff wire in the LV cavity. Once you cross the valve, get the valve loaded, check it. And what you're checking for under fluoro is to make sure these pedals, there are 2 of them, are properly positioned in the delivery system. So this will be a proper load on fluoro, and this will be a misload if one of the pedals is not fully engaged in its seating area. And what does it look like in fluoroscopy? This is the pedals, and you can see that it's in the same distance horizontally, and each one of these lines represent the crossover section of the nitinol frame, are perpendicularly and horizontally same, and the valve is not bending like a banana in any way. And what will a misload will look like? This is what a misload will look like. You can see the pedal on this side is slightly higher than here. So it's loaded well here, it's misloaded here, and you can see the valve bending slowly upwards. And you can also see some nitinol here protruding, almost mangled looking. So that is a misload. When you see this, it's absolutely important to reload, which is why you only position the stiff wire in the LV cavity until you know your valve is loaded. So the reloading part can take between 10 to 15 minutes. You remove the whole valve out, wash it, reload it again. What happens if you continue doing this? Well, you can deploy the valve, but you will not be able to resheath the valve. So that's why it's important to make sure that this part is correct. And if you do try to attempt to resheath while it's misloaded, all you'll do is massive buckling of the delivery capsule, and you will have great difficulty taking everything out of the patient if you had to. If you see any overlapping in the proximal segment, so the capsule nose cone is here, this is okay. That you do not have to. The key thing is just at the back part of the valve to make sure it's loaded correctly. I'm going to skip this part. In terms of pre-dilatation, I pre-dilate the vast majority of my patients. The only patients I do not pre-dilate are valve-in-valve cases, or somebody already has a coexisting moderate to severe AR. Otherwise, every other patient gets pre-dilated. Sizing the balloon, one size smaller than the minimum diameter of the annulus. So I would pick this rather than that to reduce the risk of ruptures and pacing requirements. So in terms of deployment, we'll take this step by step. You naturally, of course, advance the valve. This is a new teaching that has come out really in the last 3 to 4 weeks. When you're advancing the valve from the femoral artery, make sure that the flush port that you see on the delivery mechanism is pointing at 3 o'clock and maintains at 3 o'clock if possible and where possible. And the idea is that the device has now been manufactured in such a way that when this is delivered with the flush port at 3 o'clock, the three posts, commissural posts of the valve is aligned to the patient's commissural positioning. In the vast majority, of course, human anatomy varies from patient to patient, people to people. But when they looked at CT scan, advancing from the leg onwards, positioning the flush port at 3 o'clock significantly improves the alignment of the co-valve or Evolut R valve to the patient's natural anatomy. And why is this important? This allows, if you ever have to recross the frame to access coronary arteries easier. So just to make it easier for you to re-access coronary arteries if you ever have to in the future. I'm going to skip this part. So when you're advancing valve, like anything in intervention, do not force anything through. Do it always on the fluoro. When you're advancing a device such as this, and lock onto the LV wire, not on the delivery system in the capsule. The valve back to the capsule to see what's happening. But always go back and check to make sure the wire in the LV cavity hasn't moved too much forward. If you're very a self-expanding technology, then you can switch to a stiffer wire such as Langdukes. But remember, Langdukes wire is really designed to be used in a farm somewhere. It's not really designed to be used in patients or peripheral work. So keeping this wire in the LV cavity does carry significant risk of perforations. So be very, very careful when you do it. So once you've gone across the arch and positioned your valve, these are the steps you need to do. You first of all align, making sure your pigtail is in the non-coronary cusp. Once you've done that, you then cross the valve and start off at level 0, and you align your marker to be coaxial as shown here. And you keep moving your fluoro to as much LAO as possible. So I tend not to use cranial or caudal anymore. I just use the LAO view where I can. And if I'm not sure, then I go to an RAO caudal view and we'll talk about it. I've got a couple of examples there. So you can see that the operator here is trying to align the valve and he's going more and more LAO until the marker that sets the level of the valve frame so that it's far more coaxial. Now remember that the gap between the marker start to happen until the capsule part comes to the level of the marker. Don't worry about 0, 3, or 6. I'm just showing these 3 examples for illustrative purposes. You can meet many different anatomies, horizontal anatomies, very vertical anatomies, but ultimately the valve on what it looks like will be dependent on the relationship of the LVOT, the annulus, and the ascending aorta. So if you see, just keep an eye on the first AVI. In here, you can see that the valve is hugging the lesser curvature, coming right down to the greater curvature. So if you start releasing the valve as it is here right now, I'm going to pause this image, as it is here now. If you start releasing the valve, you can imagine that it will look great on this side because it'll be like 2 or 3. But once it reaches the left coronary side, it'll probably be 6 to 8. And the reason is because no matter what you do now, this valve, no matter how high you go, even if you go to 0, it will still only come to about 6 or 8 here, just because of the anatomy. Because I think what's happened here is when the operator went in, it probably went in a little deep. So he would have pulled it back up. And when he pulled it back up, it'll go from this side, as is shown here, into the lesser curvature. So when you see this, and if you think you're going to be too deep, it's almost pointless to resheath and resheath, because all you end up doing is this. You go higher here and it'll get deeper here. So once you have something like this, the only way to fix this is to fully resheath, come out of the anatomy and bring the nose cone to sort of near the STJ, and then re-advance again. So when you re-advance, the device then will follow, as you can see in image 3. I'll pause it there. It'll then follow the greater curvature, and it will get better coaxiality in the vast majority of patients. And in terms of step, very quickly, you start at 3, at 0. where the marker is at 0. And then as you're deploying, the valve sometimes moves a little forward. If it doesn't, you gently advance forward until you see up to level node 3. And then you go from there for 2/3 at control pacing. I tend to go about 160, 180 now, really, because it's only for 5 seconds. Then you stop everything, you check the positioning, and if you're happy now with the positioning, then you release. And even the release part, just to summarize, I normally wait about 15 to 20 seconds before fully releasing the system. For very obvious reason, nitinol is a self-expanding material. It does need a few minutes to fully expand and fix your valve. If you rush off and release, which is what we used to do in the past, I find that the movement of the valve is a little bit more increased. But waiting for 15 to 20 seconds gives you that time for the nitinol to fully expand and fix itself in position. So again, just remind you, 0, start off, then you keep releasing, optimize at 3. Absolute low level is 6. Anything lower than 6 is not great. So what it will look like in fluoro is you'll see the first intersection. I'm going to skip this. So this is what I'm trying to say now. As you're releasing, the marker is rising up. The capsule is actually about 1 centimeter below the marker point. So that's when you'll see the valve flaring. So it's not that the device is suddenly broken. As you're releasing, you'll need the capsule, which is about 1 centimeter below your marker, to then start releasing the valve. So from here onwards, the valve is exposed. So unfortunately, the device currently does not have a real marker to tell you where the capsule is, which is something probably you can see like a halo effect there, a bit darker. That's probably where the capsule is, but it's about 1 centimeter below the marker. And again, so I'm going to let this play on so that you can see that the valve is about 1 to 2. And from now, the valve will start getting released. The marker is up there. The capsule is somewhere halfway between the marker and the distal part. And as you're releasing, the most important part now is to maintain the coaxiality of the valve. Ignore the marker now and just look at the valve base. And if you start flaring up and you see the valve coaxiality changing, then you keep going more LAO, less LAO, and maintain the coaxiality. And from then onwards, all your eye needs to do is to look at the lowest sinus and to make sure the lowest part of your lowest valve is just below the lowest sinus. Ignore the other 3 sinuses because it doesn't really matter. You're trying to deploy a 3D device in a 3D anatomy, but using 2D imaging. So you're never going to get it right on all 3 anatomies. So just fix your eye to the lowest part of the valve, then fix your eye to the lowest sinus, whatever the 3 sinuses are. Usually it's the non-coronary. And then make sure your lowest valve is just below the lowest sinus. I'm going to let this video play. So you can see that there's control pacing now, going up to 2/3. The valve is really stable. Try to leave a gap that you can see between the radio opaque, where the anchors are, to the device marker. If you go any higher, you may not be able to recapture the device. So this is what I meant. So as you're releasing, I tend to correct this much sooner than where we are at the moment, to make sure that the base of the valve is coaxial or coplanar. And then you check to make sure, and you can see that it's about 1 there and 0 here. So today, if I see something like this, what I would do now is to go to an RAO caudal view to reassess the depth. And I think this actually will be okay to release. And then I tend to sometimes, if I feel that the valve is a little high and I'm concerned about stability, even at this point, I tend to pace about 160, 170 again, or even 180, so that there's no VPC or something like that that can actually avulse the valve during release. So here they're releasing slowly, which is fine, but you can actually rapid pace and release a little bit quicker. But just be wary about last, accidental VPC, they can actually avulse your valve while it's still attached to the delivery system. And of course, after that, you need to remove the nose cone. That is slightly over captured. And what you want to see is a slight gap between the nose cone and the capsule. So you can see the marker, the capsule ends there, and then it's a subtle marker, a subtle gap, a band to tell you what level you can stop. I'm going to skip this. So I'm going to skip this as well. The key thing I think I've changed the way I've done how deployment in the past is I now use LAO and LAO only. I don't go LAO caudal or cranial. And I found that by using the LAO only view, the outcome is similar to an RAO caudal view. And I've got just a couple of examples very quickly just to show you that, and then I'll stop. Case one was actually done in India. It's a quadratic cusp anatomy, large root, very horizontal anatomy. Transfemoral Evolut R34 was used with PIRA the 24. You can see the horizontal anatomy. Very little calcium on the views, but it is there, and we thought it was stable enough. You can quite clearly, I guess, see the quadratic cusp nature of it. Clearly horizontal, also leaking. Therefore, we did not predilate in this case. Now, the ECG is interesting. So the patient has right bundle, left ventricular block, and first degree. So a high-risk candidate for a... Can you all still hear me?
Yeah, you're still audible. Okay. Please go ahead.
Okay, so we use a comforter wire to get the support. And you can see with the comforter wire, we just were not able to cross at all. And I think at this point, with this delivery system, especially with the spines, do not push, because you can very easily dissect the aorta. So we then switched to a Lundquist wire. And that's a Lundquist in. And then you can see that be very, very careful with the Lundquist wire. And sometimes if you are having difficulty advancing, just wait a few seconds, minutes, maybe, just allowing the warmth of the device. Remember, this valve is loaded in cold solution. So plastic or any material in cold solution becomes a lot stiffer. Just allowing the valve just to warm up to body temperature makes it softer. And you think it's your skill that's getting the valve across the anatomy. It's actually the device becomes a little bit more flexible in warmth. So waiting sometimes that few more seconds, just allow the delivery system to warm up, allows the device to cross difficult arches, and the anatomy is easier. So just remember that don't try to push all the time. Just wait a minute, count to 10 or whatever it is. And then when you advance again, it seems to always go easier. And I think it's because it just warms up. So went in a bit deep, clearly. So I pull back. And here you have to align the ring. You can see the ring is not aligned. Now the ring is aligned just by going more LAO. Just we started off with 0. And at this point, the valve is just slightly exposed, and the base of the valve, or the inflow portion of the valve, is still coplanar. And all you have to do now is keep your eye to the lowest sinus angiographically, and making sure the lowest part of the valve is just below the lowest sinus. And that's all you have to do. It's really simple. You don't have to worry about what the other 3 sinuses are doing. You can almost ignore them. I'm sorry, I can't see why this is not playing. Oh, it is playing. There you are. So we're slowly releasing. And now the marker is there, the capsule is here, and now the valves are being released. And because of the anatomy, we decided to go up to 2/3 under paced control. So this is too deep, clearly. So in terms of resheathing, now the IFU will tell you to fully resheath and reposition. What you can do is to hold the delivery system. The first operator holds the delivery system fairly tightly, and the second operator then starts resheathing. By holding the delivery system, and when you start resheathing, the valve will get pulled back into the capsule, And when it does that, it'll start climbing up by itself. And once you see a better positioning, then you can release it quickly. So you do not need to go back to ground zero or zero back to complete resheath. And that's what we did here. We just started resheathing, the valve gets pulled up to more optimum position, and then we released it, and it's come up slightly higher than there. You can still see it's shallow here, it's a little deep. Now, the only way to correct this now, if you really want to correct it, is to do full resheath, what I've told you before. Come out a little bit and then go back in again. Now, in this case, we were not going to do that because we realized there was a lot of challenges recrossing the annulus. So we accepted this position and deployed it. And that was the final outcome, which is pretty good for a challenging anatomy. This patient went home a couple of days later, which is great. And the ECG did not change at all. Now, this patient got paced before going home because I felt that, with trifascicular block, is not a clever thing to send somebody like that home. But I think just to demonstrate that even with a large 34 valve, where you have the highest root pacemaker with complex anatomies, by being careful, meticulous, methodical, and controlled, you can get reproducible, good results despite having conduction challenges. One more case, if I can, and then I'll stop. Bicuspid valves, I think, are harder to deploy just to get your anatomy and orientation all right. So this is using an Evolut Pro, a transfemoral, again, local anesthetic. These are the CT sizing. You can see the eccentrically calcified anatomy. So there is a raphe that's heavily calcified. So if you're not sure whether you are on the non-coronary or not, go to an LAO view, first of all, and then go to quickly to an RAO view. And the RAO view, you should see that the pigtail sitting posteriorly. So then you know you're on the non-coronary segment rather than on the right coronary segment. So we pre-dilated I tend to routinely pre-dilate bicuspids just to give you a best chance. I think post-dilating a bicuspid carries a lot more risks and uncertainties than pre-dilatation. So we started off again, 0, aligning to the ring only. And then we started deploying, trying to maintain a 0, because my thought is that we may need to just push in a little bit as you're releasing. And you can see that's being released, still at 0. And then it started expanding. And then a 1/3 stop, reassess. Still looks good. And then from 1/3 to 2/3, we control paced at about, I think it was 160 here. And you can see the depth does not change. So that is really at the borderline of resheathing again. So you really want to see a gap between the anchor and the marker. Wait for 10-15 seconds, check your position. You can see that there is not a complete linear line there, so we realigned it, going a bit more LAO. The frame inflow portion is really aligned. Then you take a picture. So now here's where so in this view, you can see that it looks like 0 on the non-coronary, but on the left side, it looks acceptable, and very posterior looks acceptable. So when you are in doubt, I tend to go in the RAO corridor view to just double check. And the RAO corridor view is very comfortable. We are in a really nice position. So then we went back to the LAO corridor to release the valve, again, under control pacing. And you can see there's not much movements, no pings, no sudden movement of the valve frame. And really good, really good outcome with good depth and no conduction changes. So just the steps then: align your valve to anatomy, keep your eye to the lower sinus, lowest part of the frame. You just want the lowest part of the frame just below the lowest sinus, ignore the other 2 sinuses. Up to 1/3, maintain your depth. From 1/3 to 2/3 under control pacing. Check your position, be absolutely happy, because this is a fully resheathable device. You do not need to accept your first deployment as the as the correct deployment, be comfortable using it. And then if you're totally happy, release the valve either under control pacing or without pacing. Now I have this, but you know what, I'll stop now, Sai, and then we can come back to it, because it's just, unless if Sonia touches it, and don't need to go back to it. It's just a tips and tricks on how to deal with if you have a valve pop up. But I'll come back to that. So I'll stop now. Thank you.
Ganesh, it was an excellent step-by-step blow of how to deploy a self-expanding valve. And what do you want to do? Do you want to quickly finish Sushil's talk, or does anybody from the audience have any questions? A suggestion I have to make, if any of you have questions, it would be nice for you to put it up in the general chat, and I'm sure either Ganesh or Sushil would pick them up, or Dr. Petronio would pick them up and answer them to you. And you're welcome to raise your hand if you'd like to ask a question as well. But
my thought, maybe get Sushil to do the talk, because the deployment strategy will be similar in many ways for both technologies.
Exactly what I was thinking.
Sushil, yeah, and then we can have an open session, and then we'll go to Sonia maybe.
Perfect. That's exactly what I was thinking. Sounds like a plan. Before I let Sushil take the stage, again, Sushil is no stranger to India. He's the director of the Structural Heart and Valve Center at Columbia, who does over 400 cases a year. Yes, I did say 400 cases a year. And this brute experience is extremely evident every time Sushil gives a talk. It's information packed, his experience shines through. It's always a pleasure to listen to him. He started deploying these valves, I think, even before they got their CE marks. He's probably one of the most experienced operators when it comes to the balloon expandable valve, not to mention other devices and valves. With that, Sushil, floor is yours.
Sorry, can you guys hear me? Okay, sorry, I was muted there for a second. So, what are we all trying to do? We want to deploy a valve successfully that has the optimal results, but we get out of the procedure safely. And so it's really percutaneous access enclosure, successful intra-annular deployment under rapid pacing, really none or trace paravalvular AR, no major complications including stroke, vascular or bleeding, early mobilization, and early discharge at day 1 or 2. So, there's a lot that goes into a successful procedure. There's most important component in my mind is pre-procedural planning. You need to understand what are the risks in an individual patient. And we'll talk a little bit about that, but that really goes to the imaging and CT. But you have to have enough experience to understand the device and its limitations. Then also careful procedural technique. And you can do all of these things perfectly, but sometimes, as we've all seen, there's a lot of luck that goes into it, right? There's always something that catches you didn't anticipate. No matter what you do, everything you do correctly, something happens, and you can't avoid that. But you can take care of the other 3 components, and by planning, being meticulous and prepared, that's key. So I'm not going to go into all the details of screening. That's a separate session that we've done, and we'll really talk more about the imaging, but understand the limits of the device. So the balloon expandable valves, whether it's the SAPIEN 3 or MyValve from Merrill, which are very similar devices, they go through this expandable sheath, either E-sheath or the Python. And the idea is for 20 to 26 millimeter valves, it's a 14 French expandable sheath. The 29 goes through a 16 French expandable sheath. So unfortunately, this video is not playing, but I'm not sure what happened there. But you can see here the sheath the valve is coming out the side of the sheath in this particular case, because the sheath ends on a bend in the aorta, and that's where you have to be cautious when you have things that end on a bend, because now the sheath is pushing in here, and it can injure the aorta. And you'll see this case example, which unfortunately is not playing, but in that was that case example, because of the pushing and pulling, the sheath ended up perforating the abdominal aorta. Patient became hypotensive after the valve deployment. We ended up having to put an endograft to treat it. So there are cases like this. Your sheath is going to end up in this tortuous abdominal aorta. The sheath is there, and you see here that the sheath has kink. This is the 14 French BAV sheath. So in these cases, you have a pigtail from the other side. So put a Meyer wire, a Lunderquist, whatever you want, up the other side. And what that does is it straightens out the abdominal aorta for the period of time where you can advance the sheath in the delivery catheter. And then when you get your delivery catheter up, you can take the Meyer wire or Lunderquist out and then rehook up for the pigtail. Because you have access on both sides, use it, put stiff wires, make this transition in the abdominal aorta as easy as possible in cases like this. And I do this pretty routinely if there's a lot of abdominal calcification because there's no harm. You're not getting additional access. And so once the catheter's up, once the delivery system goes through, then you take it out. One of the key components of a successful procedure, is getting a coaxial view. You know, in the end, with minimalist technique, it's a fluoro-based procedure. Echo is there for assessment and for complication assessment, but it's a fluoro-based procedure. The key for a fluoro-based procedure is getting a coaxial view where all three cuffs line up, where you have a good view, you can see calcium, you can sort of in your mind visualize the landing zone. And with this, you can do this awake in a minimalist approach in the cath lab, and you don't need a lot of fancy technology. But finding a coaxial view is important in patients. And so you see here, this is an early example of a case that we did before we really understood. You see the cusps are not lined up. One cusp is much higher. And the problem when you're doing it this way is you don't know where the annular plane is. You're looking up at the annular plane rather than directly at the edge of it. And that will tend you to malposition your valve. So now most of us, what we do is we use 3-Mencio to use our to define our coaxial plane. And I think that's what, you know, we find a view here, and you see here, but 3-Mencio gives us a view. It's not always perfect, but you get a rough starting plane where with balloon expandable, I don't like the cusp overlap. I just put the right coronary cusp in the middle, and you see all three cusps nicely. And that's what we tend to do. In terms of BAV,
very quickly, there's a chat that came to say that they can't see your slides. I can see it. Can others see your slides? I can definitely see your slides.
I can see it as well.
Yeah, we can all see them. We can all see them.
Sorry, Sushil, continue.
Okay, no worries. So in terms of balloon valvuloplasty, we used to do it in every case. I've gone away for it for the most part with balloon expandable. There are certain scenarios, bicuspid valves, heavily calcified valves that I may do it, velocities of 6 and things like that. Or in scenarios where you have question about coronary occlusion or valve sizing. So when you can do BAV for either to help facilitate the valve procedure or for a diagnostic. I generally use the balloon that comes with the Edwards system. But the key things with BAV is, we do it with pacing, but don't do long pacing runs. So especially in someone with a depressed LV function, EF of 20% with high filling pressures, whenever you do long pacing runs, you create ischemia, and you sort of set the heart up for doing worse. And then what happens is when you go to deploy the valve, patient becomes hypotensive, doesn't recover. So don't do unnecessarily long pacing runs for BAVs. And again, as I said, I use it when I'm worried about the coronaries or what other things. Several people, there have been multiple studies. This is just one. People have looked at it different ways. I don't think, BAV may add to stroke risk in some studies. It may not in others. There's really no real clear advantage or disadvantage to BAV. And I think you have to individualize it to the patient. So in terms of one of the key features in my mind of the balloon expandable technology is the delivery system. The stroke rates in the SAPIEN 3 trial were 1%. And I think part of the reason is you see how we're navigating the arch, the pigtail's on the outer curve. You continue to flex and you pull wire tension. This is a completely horizontal aorta that you see here, but you're staying in the middle of the aorta. You're not scraping around the outside. I think that does reduce some embolic risk. And then when you cross, you fully flex and you try to cross in the center of the valve. You're not pushing the commissure where a lot of the calcium is and where you have a lot of resistance. And that will allow you to. So this has two flexes. It's the partial flex up here, which allows you for this part to help navigate the arch. And then the distal flex, which allows you to get very coaxial, even in a very horizontal aorta. So the key again is use the pigtail, navigate around, don't scrape on the outer side of the arch. And I think that's the key thing. With balloon expandable valves, with both MyValve and SAPIEN 3, there's clear foreshortening when you deploy these valves. And that's one of the things, when you take a big device and you crimp it down, it lengthens. So when it deploys, it's going to shorten. The shortening occurs mostly from the ventricular side, maybe 1 millimeter here, but the majority is from here. You see here, this is where it started. And this is not movement. This is just how it shortens. So when you're positioning the valve, and again, we want to end up with, in my mind, 0 to 2 millimeters below the annulus. So this is how we initially said to start where we want to position it with this central marker at the annulus, which would leave us a little bit below. I tend to be closer to this or to this even now, especially if I'm oversized, I tend to deploy a little bit higher. And the foreshortening is significant. A 20 millimeter valve has a crimp height of 21 and foreshortens 5.5. A 29 millimeter valve has a crimp height of 31 and foreshortens 8.5 millimeters. So a 30% foreshortening. So you have to account for that when you're deploying these valves. The other thing with balloon expandable and these technologies is beware of stored tension. You know, what happens here is you cross and then you use this inner shaft to pull up, right? You use this inner shaft to pull back. This is not a Sapien 3, but when you pull up with this, what it tends to do is pull tension down on the outer shaft. And you see here, we were out here, but now we've been pulled to the inner curve. And that will draw the flex cat down, and it's hugging the inner curve. And this means there's stored tension. And because you pulled up, the resistance of the valve has stored tension. And then, so you want to make sure the last movement you have is forward with the inner shaft, the balloon catheter, so you're not on the outer curve. What can happen if you don't do that? Watch out. Oh, so let me, sorry, it played fast, but let it play again here in a second. That tension as you deploy the valve is suddenly released. Let me see if it'll play again here. Can you guys see that? Is that video playing?
Yes, it
Yep,
is.
it's playing.
Okay. Anyway, you suddenly release it and the valve embolizes aortic. So I think that's one of the key things. The other thing that we always talk about as a challenge with balloon expandables and or self-expanding is more so is reducing pacemaker risk. With balloon expandable, pacemaker risks in general have been low. In the most recent Sapien 3 study, it was around 5 to 6% in low risk patients. Our initial experience was much higher, and part of the reason was we were deploying the valve too low. It's that foreshortening that we didn't account for, and that's why my goal is 0 to 2. That's why I position with the central marker a little bit higher, so that we end up at 0 to 2. You got to account for the foreshortening. If you're at 0 to 2, your pacemaker rate should be 5 to 6%. And the other component that we worry about is PVL. So you want to oversize to reduce PVL. But because of the skirt on both MyValve and Sapien 3, this sort of seals a lot of the PVL. So you don't need to oversize as much. In fact, you can get good sealing even with undersizing to -5%. And so these are the areas from 273 to 683, but we've done cases well into the 800s without an issue. And so you need to look at this for the sizing. And so in the past with Sapien XT, a size of 430, we would always put a 26. Now I do a 23 in that type of patient. And you see the rates of moderate or severe PVL are around 1%. Mild is down to about 40%. And it's very different from XT, where if you didn't oversize by at least 10%, you had PVL. Whereas here, even with 0 to -5%, your rates are in general are not, they're not perfect, but you have less than 10% moderate PVL. Ideal sizing zone is 0 to 10% oversizing, in my opinion. But the valve sizing is much more forgiving with Sapien 3. You can treat much larger annuli. I've done annuli up to 800. You can add extra volume. And I've added as much as 5 cc's because this is not like the XT stent. It's like a coronary stent. It will continue to grow. The fabric will constrain a bit, but you do have room and you can continue to grow. And so even with annuli up to 800, if you add 3, 4, 5, you can get a decent result. You're going to have some, but you're not going to have issues. And this was a publication from the center in Germany, from Munich, that looked at this. And so, a 29 valve, they made to as big as 740 on post CT. So you can get areas about 10% above nominal, and your seal zone is broader, so you can get a pretty decent result. But I think, there's bigger concern in some ways about under deployment, especially a 26. If you underfill by 2, you get leaflet dysfunction. You got to be cautious. And doing any more than that is a problem. And the reason this is relevant is there are many anatomies where you can't fully deploy because of calcium, because of annular rupture risk. You're going to have to accept PVL, but you also have to accept that you may need to under deploy a valve with balloon expandable, because if you push it, you're going to get root injury. And this was early experience showing that oversizing more than 20% and LVOT calcium are the biggest predictors of root injury. This is from the original Sapien experience in 2013, but it still applies. That's how you get root injury. The other big thing that I worry about in patients is effaced sinuses or calcified leaflets. And so you see here, the sinuses don't bulge out. and you have no room. It's like a pipe here. And you got to forgive my drawing, but I try to do it on PowerPoint. But what is an effaced sinus, and why does it matter? So normally the sinuses bulge out like this, and they're crucial for normal flow in the coronaries. But also during TAVR, they provide space for the leaflets to sit. When you have effaced sinuses, there's none of this bulging out, and there's no room for the sinuses. The definition is when the sinus width to the SDJ width is less than 5 millimeters. And this may cause problems. And you see here, there's not room for the calcified leaflet to sit. Watch what happens with even 5 cc's left. You see what's going on? The calcium is pushing into the root. And if you just suddenly deploy that, then you're going to have a problem. And I think that's the thing you have to be cautious about. You got to do slow. We had 5 cc's left when it started bulging. And if you go slow, you reduce your risk of root injury. And the analogy I use is if you take a balloon and you have a pin, to some extent, you can push the pin into the balloon and it won't pop because you're doing slow pressure and it's distributing. If I take that pin and I go like this, it's going to pop. So don't just slam all the volume in. That's how you're going to injure the root in some of these cases. In this case, there was significant PVL. We underdeployed, but we did post-dilatation slowly and gave back volume. And in the end, we had less PVL. But this is a case that I would do asleep without with TE because I think the imaging is important. It's a risk-benefit decision about asleep versus awake. If you don't do this and you pop it, this is what you get: hematoma, root dissection, root rupture. So those are the things I would be very cautious about. Coronary obstruction, again, the biggest predictors are low coronaries and small sinuses. Same is true for balloon expandable versus self-expanding. And you want to put a virtual valve and see is there room for the valve to sit. In the majority of cases, your valve is going to sit below the coronaries. But there are cases where you are concerned, and take a look, do fluoroscopic TE guidance. We did an injection. There's still risk. Oops, that's 14 minutes. I got 1 minute left. So you see the left coronary cusp, the calcium goes directly into it. And so if you have a high risk for inclusion of the coronary, I put a stent in here, and that's what I did. I have a stent in the LAD. I've backed the guide out into the aorta. I use a side hole guide, so I don't need a separate catheter to inject, but the guide has side holes, so I can inject and take a look. And then I have this stent ready. So I deploy the valve, and as we were sort of worried about, it's not the valve, but the native leaflet is pushed above the coronary. The valve deployment was fine, but the patient got hypotensive. There wasn't laminar flow, and angiography, we had occlusion. So then basically pull the stent back. Now, when you're stenting here, you need to you stent to the frame. You don't want to go beyond, you don't want to stop at the ostium. You got to stent the valve away from the frame. But if you're prepared, it's the patient we did, and the patient still left the next day. But you got to be prepared to handle those type of things. The last thing I want to talk about was TAVR and bicuspid valves with balloon expandable. Asymmetric annulus, the concerns are PVL. You don't seal at the gaps. You're not deploying symmetrically. And I think that's one of the challenges. The heavily calcified raphe, when you deploy a balloon expandable, this raphe is going to keep it from expanding in this direction. The valve is going to move in this direction. And that's how you get the annular or root rupture. Non-circular deployment, because of this raphe, you might deploy like this. And what that can lead to is this. You see, we're a little bit elliptical in this case. And this leaflet is not opening because we sort of pinched the commissures. And that may affect durability. In common pathology, they're associated with the aorta. But this was from the US TVT registry. Raj Makkar published this. And again, it showed that in general, bicuspid valves do pretty well, but they're at slightly higher rates of conversion to open surgery and higher rates of annular rupture, 0.3% versus less than 0.1%. And the need for a second valve is a little bit higher. So when you're looking at an anatomies like this, think about where you're going to seal. Are you sealing at the annulus, or are you sealing the leaflets? In this type of thing with a balloon expandable, you're still sealing at the leaflets, and these have tall leaflets. You need to deploy high if the seal is occurring at the leaflets, above the annulus, the same as you do for self-expanding. And so, and the other question is, will this raphe sort of split? And if you split, then you're not going to seal at the leaflets anymore. You're going to have to seal at the annulus. But these raphe are going to dictate how this valve expands. This is an area 550, large sinuses, 34, but a small left coronary cusp and a raphe. And so we did a 26 balloon. The area is around 550. and we decided based on that to do a 26 millimeter Sapien 3. You see the deployment is fairly uneventful, goes well, but immediately after deployment, patient became hypotensive. So, the EF dropped, VT, VF, that got CPR. And you see here, no flow in the left coronary. We had sinuses of 34. So how is that possible? And so we had a patient on ECMO. You see the leaflet here is sealing to the sinus and occluding flow into the left cusp. And so what really happened is the valve didn't deploy central, in which case there would be plenty of room. That raphe of the right non pushed the valve towards the left. So you weren't deployed here, you're deployed here, and this left cusp sort of sealed the sinus. And that's what we've seen here. And you got to look at the coronary length and these type of things in asymmetric, and especially in balloon expandable. I think this is a concern, and you have to be a little bit cautious with bicuspids in this nature. Lastly, same as Ganesh said, wire manipulation. The majority of perforations are not root ruptures. The majority of perforations are being careless with the pacemaker or with the LV wire. And you see here this wire kinked in trying to do it. We're not using pre-shaped wires. I think the pre-shaped wires reduce the risk of that, but basically there was an LV rupture from that. The other thing is loss of capture. These are the silly things that can be an avoidable complication, because you put a pacemaker in and you're doing all this stuff with the big sheath. The pacemaker gets pulled back a little bit. You don't notice it, and you do pacing, and then you lose capture, and the valve embolizes because you see here initially lost capture, regained capture, and then lost capture again with the balloon fully inflated. And so here there's a big beat, and that ejects the valve. So being very cautious when you put the pacemaker in. Make sure you don't push too hard. Make sure you don't perf. I use a balloon tip. Make sure you suture it in, cover it with towels so it doesn't get caught with all the other stuff and you don't pull it back. And then make sure the person operating the pacemaker knows what they're doing. So one of the things that I'm always afraid of is when I'm going up with the valve, I'll tell the fellow, if it's heavily calcified, I'll say, stop inflating, because there's a lot of resistance. If they stop inflating, I don't want the person to think that stop means stop pacer, because if they stop when you say stop inflating, they stop the pacer, that's what's going to embolize. So I've made it very clear the instructions have to be pacemaker off, not stop, because when you use stop, that's the challenge. But it's become balloon expandable TAVR has become a reliable and predictable procedure. Understand the limitations of the device are important to prevent complications. CT scan imaging is instrumental to understanding individual patient risk. And I can't emphasize that enough. Whoever's doing the procedure needs to look at the scans. You need to look at the scans, and you need to, based on that, understand risk and then carefully plan and execute the procedure to minimize risk and optimize outcomes. Thanks a lot.
Sushil, what an excellent lecture, Sushil. I mean, I could literally listen to you all day.
No.
I love the way it's systematic, blow by blow. Just one question before I open the house to questions is, you said that this balloon expandable valve, like a stent, can just keep going up. At what point are you worried about non-coaptation of the leaflets?
So, we haven't seen much central. It won't keep going up because the skirt and the fabric will keep it from expanding. So I think we can get it to about 750, which is, about, 10 to 15% above in terms of area. But because you seal at the leaflets and you have a heavy calcium, we've treated annuli and leaflets, that are much bigger, 800 plus. And you might get some leak, but that's acceptable.
So the integrity will be maintained by the mesh around.
Because they have a larger coaptation zone than the original XT. You couldn't do that with XT because you get central.
Central,
With,
that's what it's
3, yeah, and with my valve as well to an extent. I don't know it as well, but you have enough coaptation length that you won't get central.
Very quickly, I would like Dr. Petronio to give her comments. She's heard both Sushil and Ganesh, the self and the balloon expandable valve. So, Dr. Petronio, could you take a couple of minutes and give us what you feel about both these procedures? Unmute, Dr.
First of all, I would say that it is very important what Ganesh said at the beginning. So when you begin with one valve. You begin with one valve and try to understand exactly how it works and get used to it. But I really think that you need to be able to be very good in at least 2 or 3 different kinds of valve, especially when the numbers that are growing in a cath lab or an OR over, let's say, even for the small centers, 50 or 100 valves per year. But the important is to begin and be very, very used to one and then go to the second one. And because each valve has the pros and the cons, and I think you have to adapt the valve to the patient. So you need to have the best valve for that patient. And this means that you've got to understand all the things that Ganesh said and Kodali said about balloon self-expandable valve. And you have to do that with the anatomy of the annulus, of the aorta, and of the axis. So you've got to balance the two and then decide. So I think it was very interesting to hear all the tips and tricks of both kinds of valves.
Where are my manners? I would first want to introduce Dr. Sonia Petronio. Dr. Petronio is not only the head of the cardiac catheterization lab at the University at Pisa, Italy, but she also heads the cardiothoracic and the vascular surgery departments. That's quite a bit for a cardiologist. She is an excellent operator.
We work together with a surgeon.
I like the modesty. She's an excellent operator, a patient teacher with over 250 publications to her credit. And we've been trying to bag her and bring her to India for about 6 months now. And just when she finally gave in and said she'd come, COVID happened. And this is the best we can do. And very quickly, before I give the stage to you, Dr. Petronio, I would like to welcome some of our prolific proctors from across Asia. There are a lot of doctors here. There's Edgar Tay, who's from Singapore. Hi, Edgar, it's nice to see you. There's Wilfred D, who's from Philippines. And of course, Dr. Teguh Santoso. Who doesn't know Dr. Santoso from Indonesia? And it's so nice to see all our friends. Of course, there's Dr. Atul Mathur and so many familiar faces. If any of you would like to ask any questions at this point, please just, admin, could you unmute or make Dr. Edgar, Dr. Santoso, Atul, all of them co-hosts at this point. So if they would like to ask anything, give any comments, we'd all be so happy to hear from them. Are we all good? Okay. So I guess we will have them back in a bit. But with that, Dr. Sonia, the floor is all yours.
Okay.
We're looking forward to your talk.
Okay. Can you see my slides?
Yeah.
Very clearly.
Okay, it's good. So I was asked to speak about challenging during valve deployment, and most of the things have already been said, because we all know that the principles challenging are exactly what has been said from Sushil and Ganesh. But I would like to sort of point out, I mean, I did this sort of numbers of things that came up to my mind, which are the horizontal aorta. We saw a beautiful case about it. Heavy calcified valves, large annulus. And then what has been partially said from the other talks is the risk of coronary occlusion and the cusp alignment. And I think that the last two things, today's, that we are managing already low-risk patient and younger patient, are probably one of the main subjects we would like to talk about. I tried to show a few cases, one for each example. But I mean, what I would like to add is that when I manage horizontal aorta, I always try to think about balloon expandable, because as has been said, it is very easy to orientate and put the valve as more perpendicular as possible, especially with the being able of bending the commander, which is the delivery system of the balloon expandable valve. So this is an example I can show you, and you will see this was done with an ordinary super stiff wire. And you can see that if you enlarge the valve slowly and are able to accommodate the valve being quite coaxial to the annulus, and this was I think a 65 angulation of the valve. Of course, in this case, I think that Sushil will agree with me that you have to inflate very slowly and be like this. The first operator is able to push gently the valve like this. It's more coaxial to the aorta, depending on how much it's horizontal. And this is, of course, this the example and the last imaging of this case. When we talk about heavy calcified valve, well, there is a lot to talk about this, because it's not only the amount of calcium that we know that we are able to evaluate with the 3-Mensio system. We already could have an agostone without contrast CT evaluation, and it is even very important to evaluate the distribution of the calcium, because it has been said is that, for instance, it is important to see the calcification on the leaflets, but it's also important to see, like in this case, the distribution in the LVOT. You can even change the valve if you think that the LVOT can be dangerous for an annulus rupture, because it has been demonstrated that the LVOT calcification is one of the most important predicting factors of annulus valve rupture. This is an example of an horizontal aorta with high calcium, like the CT you saw before. And we generally decide to predilate with an underestimation of the band. This was a 20-size balloon. And you can see that it's lipping because the balloon is quite small. Personally, we don't believe that predilatation in a calcified, it can increase the risk of stroke. We think that in a heavy calcified valve, if you predilate, the risk it's reduced, because you don't scratch on the heavy calcified valve while you go through the annulus with the system. This case was done with an Evolut valve. It was an Evolut Pro 29. And you can see here that we did exactly what was described by Ganesh. So we tried to play with the wire, pushing the wire with a nice bend. This was already pre-shaped wire. And while the second operator was pushing the valve, very carefully, of course, the first operator was pushing the system to make the valve completely horizontal. In this way, you are able to manage with the self-expanding valve with the same results as with a balloon expandable valve. Of course, you choose the two depending on your skill and depending even on the access of the patient, depending on many other things that are not made by either the amount of calcium or the horizontal aorta. We come back to the case, and you can see here that at the end of the deployment, there was a little bit of, you can see here, under expansion of the valve, which can be quite typical in a very high calcified valve. And so we did a post-dilatation with a 25. And it is important even to say, in my point of view, is that the balloon that you choose, you don't choose it with a valve, you choose it with the annulus. You must not exceed the balloon dimensions, but you've got to remember what was the anatomy of the valve you are working on. And this is the last angio of the vein. Another thing that is quite more use for instance, in Northern European country or United States population more than in Italy, that we are more small and not very big. It's the large annulus. Well, large annulus, you saw that you can oversize, for instance, the balloon expandable valve, but this case in particular, for instance, was a very, very large patient with a very, very large perimeter with the derived diameter of nearly 30. So you can see here that the annulus was calcified, not terribly calcified, and the cusp were very big. So one thing that you can do here when you are at the limits of a valve, if you don't want to oversize or you're not able to oversize too much because you are nearly at the borderline of the dimension, is to don't predilate at all. You just go with the valve, and you would like to seal with the calcified cusps. Instead, in this case, we did a very, very small predilatation with a 22. Remember, the diameter was 29. This was a 34 valve. And what can be easy to reach the right height in a very large annulus is to help yourself in what we call not a normal pacing, but a controlled pacing. You just try to lower the pressure under 100, and like this, you are able to to stabilize the valve while you open the valve, especially in the first part of the dilatation. Here, it's the control of the deployment, and you see here that we are controlling and ending. This part is quite high, but in the self-expanding valves, this is something that you will find is that sometimes while they are deployed and they're sticked in the annulus, they're not completely perpendicular in axis with the aorta. So when you look underneath, you have to remember that this valve is going to move and to get coaxial to the aorta. So what will happen to this valve is that here it will go 1 millimeter down if you help by pushing gently the valve while you are ending the deployment. And this is the last angel. Now, my talk is going to be more on coronary arteries and how we can manage, because I think it's, as I said before, it's very important. We have a prevalence of a very high number of patients with coronary artery disease and aortic stenosis. And the success of being able to treat a patient with PCI after TAVR sometimes has to be calculated from the beginning, because sometimes it has a high rate of success. But we have to think that these patients sometimes are treated in centers that are not used to TAVR valves. And so when they happen to have a coronary problem in a patient with a TAVR valve, they get in the panic. So they need to understand that they are able to do an angio and they are able to do a PCI after a TAVR. So it is important also to be able to predict the rotation. I mean, surgeons are very able to suture their valves exactly in the same alignment of the native valve. And so I think that we should do the same. And it's very important to do that nowadays. Another important aspect is when you have to deal with valve-in-valves, that the problem of coronary can get more important, and probably in the future, TAVR-in-TAVR will be something that we will do. and the engagement of coronary artery will be important at the same time. So what is the field? I mean, which are the patients that need a coronary angio and a coronary PCI? How many are they? Well, in this paper, you can see that, especially in the first year after TAVR, there is quite a high amount, not a lot, but a considerable number of patients that is going to grow the moment that we will treat a higher number of younger patients than very, very old. Are you able to engage when there are few papers, and both for SAPIEN and for self-expanding valve, we know that the rate of angiography is high, it's very close to 100, and post-PCI it's already high, but sometimes happens that we have some problems to deal with engaging a guiding catheter in the valve. So another important aspect is that a high amount of these patients that come to the cath lab with coronary problems are acute patients. So they are not a stable patient. And this makes things even, I think, more important. This is an example of a patient that was treated in 2012 and came last year with some coronary problems, especially in the proximal left descending, and we've been treating. You can see that both the diagnostic catheter and the guiding catheter were able to get inside the cell and inside the coronary ostia. But this doesn't happen always. This is a very old case. This was a case done with a core valve, was the old system generation of the Medtronic system. And you can see here that we were able to see the coronary arteries of this patient, but we would not have been able, or with some difficulties, to treat the patient, and luckily didn't have coronary problems. This is the right angio, and this is to show you the aorta, angio in the aorta, to be able to see the coronary better than we were able with the normal angiographic catheter. So the risk of coronary occlusion, it is low, but when it happens that you are not able to engage the coronary artery, this makes things a little bit more heavy, with a high amount of mortality. And this is done if you have already TAVI, but it happens, as has been shown from Sushil, when the risk of occlusion during TAVI procedure, which can be the case if you have the sinus of Valsalva that are very small, for instance, or if you are doing a procedure with valve in valve, with some kinds of valve, like stentless valve, like the MitraClip valves, that where the leaflets of the valve go outside the castle of the old surgical valve. What happens when a coronary occlusion comes? In this case, I said the percent is very low, but the mortality, when you are not able, it is very high, which is over the 50%. So you need to be able to avoid this risk. With the computer tomography assessment, you are able to understand if you will be able, if there is a risk of closing with the leaflets the sinus if it's small, or if the sinus or the space left outside the valve, it is too small. So what are you able to do? Well, there are few technical situations, technical skills that they are new, like basilica technique, which is very complicated. I'm not going to talk about this, but you need to know that it's possible, and it's a new technique and you need to get very skilled on it. You're not able to do it just to try. Another is, and has been shown already, is to protect the coronary artery with a wire and with a stent. Most of the time that you decide to protect, you will need the stent. So what generally happens is that you put already the wire and the stent inside the descending aorta. And then when you are, in this case, it is a self-expanding valve, you're already at 2/3 of the deployment. Then you deploy the stent and you release the valve, like in this case. And this allows you to be able to avoid that any native cusp or of the old biological surgical valve gets engaged in the coronary osseous. So the last thing I would like to talk about is the commissure alignment. Ganesh said this just at the beginning of his talk. And I think that it is something that we should get very skilled about it. Unfortunately, you're not able to do it with all valves. You are able to do it only with, at the moment, only with the self-expanding valve, but I'm sure that the new generation will do that. And the reason to do so, as I already said so, it is the avoidance of coronary occlusion, being able to do a TAVR and TAVR, and to do something like it's being done already with surgery. And for instance, look, this case where I already showed you, were not able, and the reason that we were not able to engage was exactly that one of the struts were exactly in the middle, in front of the coronary ostia. There have been some studies about, and this is very nice because you can see that it has been shown that with many valves, you are able to align, to not align, or to mildly misalign your new valve with the native commissure. Instead, you are able to do a very good job with surgical valves. So how can you manage with the TAVR? Now, with this system, your new system of the Evolut, we already saw that you have one of the pads that has a C mark, which is the anterior, that is exactly coincidence with the commissure that divides the anterior right to the anterior left cusps. And it is aligned with the L shape of the marker on top of the capsule. And this is very important because we are able with angio to recognize the position of the commissure through this marker. And as it has been said, to obtain the position, the correct position, you have to rotate the flush on the delivery system by going at 3 o'clock and rotating, going away from the operator. In this way, you will find that the marker is going to be in the outer curve of the aorta. So like this, you will see the marker is thicker here than here. And in this position has been found that the cases where the commissure is exactly coincidence with the native commissure between the right and the left anterior cusps, it is very, very high. You can see here the position and the last position of the pad with exactly the position of the commissures. It has been done this also for the balloon expandable. They tried to find if there was one possible crimping that gave you more allowance. Now, it was not possible to find this. We have to say that with Edwards valve, the frames are very, very big, and so it's quite easy to get inside the coronary arteries. I hope that Sushil will agree with me. But anyway, I hope that in the future, any valve will try to find the commissure alignment for that certain valve. I will show you to end one case with a valve-in-valve, with a valve-in-valve with the Perimount mania of 25 of a patient that had 71 years old, quite young. It had a lot of comorbidities. We decided that it was a valve-in-valve, and so TAVI was the best thing for him. But we wanted to guarantee him the chance of being able to have, in the future, a coronary procedure because he had a history of coronary artery disease. So what we did before aligning the valve, we are lucky because we have the CT that is together with the fluoro. It is so we are able to see the imaging of the CT together with fluoro, and we were able to isolate the three the three commissures of the Paramount valve, and we knew exactly where was the ostia of the left coronary artery. So we did our alignment, and you can see here that the marker was in the outer curve. We got inside in this position, so we were quite sure that after that the new commissure was going to be exactly in the same part, in the same point of the one of the biological valve, and it's the result. So you can see here the pad, you can see here the commissure, you can see here just to make sure we put a catheter to visualize the left coronary artery. And I think that at the end, this is one of the most important things that we should do. And when we plan a TAVI, we have to think on the future, because a patient of 70 years old will probably have a long history of valve in compared to the patient that we used to do 5 or 6 years ago of 85 or 89 years old. That's all.
Thank you for an excellent lecture, Dr. Petronio. Thank you so much. Just before we move on or take any questions, I have a couple of things that I'd like to say. Especially when it comes to the self-expanding valve, the first thing that all of us should learn to master is what Ganesh said, which is go in with the valve, because as you move forward, you have the highest chance of coaxiality, and then keep it at 0 at the NCC. And as you open and the metal of the valve is exposed, you actually anchor on the calcium in the NCC. And even if you're not coaxial, you can then push and lay over the valve. Ganesh, please stop me if I'm wrong. Lay over the valve to get a good coaxiality and then release the valve beautifully. Now, there are a couple of things that you can do during this. You can actually rapid pace the valve if you find it's catching the cardiac output and bobbing in and out. Because if all balloon expandable operators do it, why not we as self-expandable operators? But I have encountered problems with that. While it works well in most of the cases, especially in some valve-in-valves, or some cases where there's no calcium on the NCC, I've become quite fond of using the wire. I know Ganesh sometimes is tempted to wrap me on my fingers, especially when you take the Lundquist wire. I like to shape it, and the transition zone, unfortunately, is not radiopaque. I don't know how they missed that one out. But so what I like to do is I curve it. No, just think about it. All they had to do was put a radiopaque marker where it is. So I like to actually bend it away from the LV, because the DC has such a big curve. Sometimes the semi-floppy part is at the annulus and it just buckles. So once I get the curve in a nice place, provided the LV is big enough, even the Landakus is quite safe because the transition points of pressure are distributed. But you have to be very, very careful again. But with a Confida, I feel extremely comfortable for doing two things. One is pushing on the wire and keeping a tension in the system which prevents the bobbing. A second thing is to make it coaxial. And I'm saying this so brazenly because I saw all of Dr. Sonia's videos where she's done that. Otherwise, I know I'd have to hear a earful from Ganesh and Sushil. Having said that, the floor is open to Ganesh, Sushil. Dr. Sonia, defend me, please. Yes.
I guess one of the key thing about TAVI today is there are many, many ways to get the final result correct. But the only way you can achieve that is by knowing your technology really, really well. And then learning the wires that you're using, like coronary intervention. We all have our favorite wires, we all have our favorite catheters and guide catheters, and then you learn the limitations of your own skill, and you compensate it by taking technologies that will support your skills. So I think using the wire is safe as long as Sonia very correctly said, you need to be really, really careful of how much you're pushing. So the person who's pushing cannot be a fellow. The person who's pushing the wire needs to be somebody who knows that they get the tactile feel back. And sometimes you don't get the tactile feel back if it's very tortuous access or arch. And in those cases, that's why I think trying to use reseatable feature more than using the wire probably has a better advantage. And I think if somebody's really, really so tortuous, I think the Sapien has a clear advantage in a very horizontal anatomy. You really don't have to worry about wire control at all. The device is beautifully manufactured for you to align your valve to the anatomy. So I think I'll probably stop this. Sushil, have you any?
Yeah, I mean, I think similar. I was going to say the same point. I think in the end, when you have multiple devices, there are certain anatomies that I favor balloon expandable versus self-expanding, and vice versa. So I think, but the challenge here is, we said to start though, people should get used to one valve. So you don't have that luxury. So the question is, it goes back to the same point, and we've talked about this in the past sessions as well. Understanding individualized patient risk based on the CT. I think with CT, we know patient risk. So if you're doing a horizontal aorta with a 34 evolute, that's not a great case. And if it's, if you're doing one case a month, that's challenging. Now, if you say that you need to give patients access to care and you need to do that case, then what I would say is also from the proctoring side, these are not cases where you're aiming for a 0 or 1 implant to reduce pacemaker risk. Because, and I think you have to take risk benefit trade-offs, and being at 4 or 5 in getting out of the case successfully is better than popping out a valve in a horizontal bicuspid valve. So understanding individual risk, understanding what your goals are, and the goals are to get a valve in, minimal leak, and get out of the procedure safely. And if you do 500 cases a year versus 5 a year, you're going to be different in how you approach it. And I think from a proctor standpoint as well, we have to be careful in how we teach it to different individuals in different centers. And I think you have to use caution in some of those things. And it's not about perfection. It's about the clinical goal for the individual patient.
Yes, I perfectly agree. I mean, what I wanted to point out is that, I mean, we were concentrating on deployment, but of course, when you pick up, you look a patient, you have to, at the CT, you have to plan everything. So sometimes you would put, self-expanding, and then you have to put balloon expandable for other reasons, or the other way around. So you really need to do what is the best for the patient. And if there's something that you are not used to it, then you could even plan to, call somebody and say, look, let's do it together because it's my first time.
Absolutely. So well put. So with this, I think Ganesh, Sushil, Dr. Petronio will go on to the case presentation and then take a break. And Edgar, Wilfred, Dr. Santoso, Atul, all of you are co-hosts. Feel free to jump in at any point of time. Shall I just go on to my case then?
Yes.
Yeah, go ahead.
Here we go. So the patient I have to discuss today is a 78-year-old man, diabetic and hypertensive for 20 years, diagnosed with severe symptomatic AS in June 2016, has been avoiding TAVR because he was graded high-risk patient. Valve area was 0.4. His mean grading was 93. He was a surgical turn down. Otherwise fit guy, but very frail, very tiny guy. Was a severe asthmatic, 78 years, normal coronaries. The surgeons didn't want to take him. And what makes any case infinitely more challenging, and this is my opinion, I don't know whether Sushil and Dr. Petronia will agree, is that if they're known to you. And this patient was my best friend's doctor's father, which means my pet, Bolt, my dog, okay? So he was my veterinarian's father, which makes it that much more challenging for me. So this was the case. And Sushil, I know Dr. Petronia will be gentle because she's just met me, and Ganesh will be kind, but this is specifically for you. This was very early in my implant. As you can see, it was about 2 years back. So I'm giving the caveat before I go on. This is the case. This is the Medtronic report of the patient. As you can see, the femorals are all decent size. The coronaries are nice and high. The valve is clearly a 29 valve, and I have 32 sinuses, so everything looked quite okay. And I want you to, at this point, focus on this absolute rock of calcium, okay? So it's going to come up to haunt us as the case goes on, but other than that, nothing great from this. Sushil, please tell me if I'm going too fast or if you want me to slow down, okay?
That's perfect.
Okay, so this is the patient, this is the root angio. You can see that chunk of calcium towards the LCC, huge wad of calcium. Took a 22 balloon, even though the minimum diameter was 22, because I was anticipating problem from the calcium. Again, Sushil, early in the career, case 41, be gentle. Okay, so I left the patient details on. Just want to tell you that the patient details are there with requisite permissions from the patient. So took a 22 balloon, hit it hard, and this is the valve. I'm shamelessly partial to the self-expanding valve, and that's the valve. It's my first go-to valve. As you can see, the implant depth looks okay, and at this point of time, I was quite happy. I was at about 3 to 4 millimeters. It was nice and coaxial. I got the wire in, and now everything's okay. There is a significant leak, but at this point, I predominantly tend to look at the position. I don't think of the leak that much. So release the valve. It was a good release. After release, this is what left. You can see the LAO and RAO projections. You can see the valve significantly. So you can see the valve significantly compressed in the RAO. The gradient was 23 and the AR index was 19. So at this point of time, did the most logical thing that I could think of doing, which is a postal with a 23 balloon. So especially when there's this much calcium, I don't straight away like to go to the biggest balloon. I kind of milk it up, so I feel it's less traumatic on the annulus. So this is a 23 balloon. You can see how the tips of the valve are flaying out. It was a good post-dill. Valve looks much better, but now there's no gradient, but same AR. So this is where I am. I quickly pulled up this so that it's easy to reference it and I don't have to go forward and backward. What next? Sonia, Sushil, Ganesh, would you go in? Would you go ahead with a 25 balloon? Would you leave it alone?
Can you hear me?
Sorry, Sushil, go ahead.
Yeah, sorry. No, I mean, I think that with the AR index, with what you're seeing, angio, I don't think you can leave alone. I think this patient is not going to do well with this degree of AR, especially with a small, thick LV as well. The issue with going to a 25, what you see is also the valve is compressing and it's being milked by the calcium of the valve.
Absolutely, in the NCC.
Yeah, and you see that it's infolded in that direction there. And when you come with the balloon, the risk is as you inflate, the balloon comes in this orientation, the balloon sits like this. And I think you have to be careful when you balloon these. If your balloon is sitting like this, as you inflate, the balloon is going to rotate this way. And it's going to exert force outward, especially at the NCC, and it's going to tend to pop this out. If you are going to post-dilate this, which is not unreasonable, because you have enough sinuses. When you go with the balloon, with the wire, before you inflate the balloon, make sure your forces, and even take the time to check in multiple views that you're coaxial to the frame of the core valve. So you're not putting any unnecessary tensions that will move the valve. I would, if you have a TE, there's also some options as well. Then you can also consider plugging. In some cases, if the anatomy dictates you're not going to expand, I put a plug in these type of scenarios as well.
You know, I don't think it helps in the discussion on the paravalvular leak, but you know, I'm not able to evaluate the CT as I looked now. I would like to go up and down. It could be a bicuspid.
So
it could be a bicuspid with a calcified raphe, and that raphe, that's why it didn't open.
So I'm going to go back up and show you. It was clearly a tricuspid, Dr. Petronio. I saw the runs. I saw everything. You can see that thing. It's just a huge rock of calcium sitting on that leaflet. So I'm going to move on now.
So the only thing I would have done differently, Sai, before you do that, is I probably would not have released the valve when it's so underexpanded.
So you might have taken it back and hit it, but Ganesh, I already pre-dilated with a 22 balloon. What would you have done?
But what I've done more and more is to go back again with another 22 balloon. And then, because once you release the valve, you're now going to a completely different pathway, which is unpredictable.
Okay.
Before you release the valve,
you'd have hit it again and again with a 22 till you got like hammering a nail.
Yeah, but I would just, usually the second or third time may be enough. Because the balloon actually didn't give you much indication that there was an issue, because your first pre-dilatation looked good.
Very good.
But there's clearly an issue there. And I think this is where when you see that much under expansion, you're only expanded by about 50-60%. You have another 40% expansion to do. That is a long area for this valve to expand to get a reasonable outcome. So I would personally have nowadays I would just resheet, take it out, because it is a resheetable technology, and because you can do easily 2, 3, 4 resheets if you need it. I would pre-dilate it again or even take a more aggressive balloon that, rather than Zima, to take one of those Kevlar balloons, take a 20 Kevlar where you know for sure it will
Ganesh, I had no waste, nothing. The balloon opened so beautifully. It was a 22. I didn't even go -1. Minimum diameter was 22. I was happy.
I think, but because the first deployment was clearly underexpanded and you're almost halfway only to the other side, I would not have released it. I would have taken it out and gone with the balloon again.
Perfect. So
it's anything I would have done differently. It may or may not change what you end up doing.
No. That's the whole point of this, right? Because I have learned from this case, and I have learned from this case, and I will tell you, it doesn't stop here. It gets more interesting. Huh? So what I like to do with the postal, when I have these 0 positions, is that just as the balloon catches the valve, I actually push down on the entire balloon and pull back on the wire a little and take it to the outer curvature. So I make sure there's forward pressure so that it keeps the balloon, it keeps the valve from coming back out. So hit it really hard. You can see how hard I hit it with the 25 balloon. Hit it really hard. The valve looks even better. But AR index is still 22 and doesn't seem to have made a difference to the AR. Okay, so these are the specs again. AR index 22, moderate AR, valve is nicely opened. That leaflet is unyielding. Now what? Sushil already mentioned vascular plug. In interest of time, I'm going to just go on after this now what, and let you all bash me if you have to when I show you what I did next. Okay. So Sushil,
the only thing I would say is I think it's worth putting a TE probe down to understand why you have AR.
So there was a TE. There was a TE probe, and the TE showed that the valve was actually circular, but the LCC leaflet had just not moved at all. It was like a rock denting the valve right there and creating a clear path for which it was leaking from either side of the calcium. It was not one jet. It was 2 jets that were free flowing, and that was not folding up. It was just not moving out of the way. And I actually had the TE during one of the sessions. So at like I said,
Looked up.
like I said, it was at that point of time, I took some time, I was 2.5 hours into the procedure. His mean gradient was 100. It was a highly pressure overloaded LV. I was not comfortable leaving him with this much of volume overload. I didn't think he'd do well. He was otherwise a fit man. He had pristine coronaries at 78. So I know that if I take a second valve, I'm kissing the coronary axis goodbye. But this was my reasoning. Giving more radial strength, because this was in 2018, and I said it was under my 50 valves, giving more radial strength as the tip of the valve was in zero position was not strong enough to give me what I needed. And I wanted to do a slightly deeper implant because my TE guy couldn't see it on the NCC side at all. And you'll see it's almost at 0 to -1 on the NCC. So I thought a slightly deeper implant on the NCC will give a better seal and I'll reduce the AR. Does anybody want to go after me for this reasoning?
No, a second valve always will improve AR in both any technologies. It just, you get a bigger skirt, you see. So then the native leaflets will match up further up with the first valve's leaflets, and you form the seal actually then occurs supraannularly rather than at the annular level.
So it's a reasonable choice, Ganesh. This you would have considered this?
I think
sure?
the next, I mean, historically, when we first started TAVI back, Sonia will know this, in the nice old days where we all blind, deaf, and dumb. and the idea was that when you put a 29 valve, the nomenclature would suggest that you take a 28 balloon to post dilate.
Oh God.
But now we are all at least partially blind, partially deaf, and partially dumb. we now know that in this anatomy, if we take a 28 balloon,
we'll rupture the
it will
annulus.
be a catastrophic outcome.
Yeah.
I think a second valve or a plug, as Sushil suggested, if you have, are the only two options available now.
Okay.
Correct.
So I took the second valve, and there was intentionally, I didn't snare the first valve. I was wishfully thinking this valve would move the first valve a little down and I could take out the second valve because I'm still thinking of his coronaries. It didn't happen. Very slowly, I moved the second valve in. And as you can see, I kind of played with the wire, tilted it. So I went deeper on the NCC because the LCC was already 4 millimeters, 5 millimeters deep. I didn't want to go deeper there. So tilted it a little, got it as best as I could think it was. You can see the rapid pacing to help me control it better, and the quick release so that it catches on and doesn't move. Let it sit for a while. There's your TE, Sushil. I didn't forget it. So I had the TE in, checked everything. I was extremely happy with where it looked. And a really good post-dill.
God. It's too
Yes.
high.
Oh God, you saw the second image already. Yeah? Okay. Wait. Let me finish. The really good post-dill. Look at that. Look at the splaying of the tips of the valve. You know, I would have closed a coronary the way I post-dilated this. And I feel so happy with myself. I see diastolic pressure of 50. So I've maxed him out on dye with all the contrast shots. I've maxed him out on radiation. I'm 4 hours into the procedure. This was my 15th or 20th Proctor free case, 2 years back. What next?
What's the diastolic pressure now?
It's about 50. AR index is 24.
I probably would stop now, actually.
Ganesh, I feel so happy that I think like you. Sushil?
Because
No, what was your LVEDP? I mean, and again, the AR index, if your heart rate is slow, that's obviously different. So,
Correct.
but
Correct.
you know, but
it's
the
more the
LVEDP
4
is-
hours concerns me.
So,
after
4 hours,
3
Sushil.
hours, most unless you EP cardiologists, don't think normally. So
I can't believe I didn't come to this slide and stop. It's my favorite slide. So at this point, what I did is I asked my anesthetist, how bad is the CVP? Because it was the best indication of the LVEDP at that point of time, how he was. So he said he's behaving quite well, much better than before. I think I can comfortably get him off. And I thought about it. Do I want to go in now, take another 45 minutes to identify where it's coming from, put 2 plugs on either side of the vessel, or if he doesn't stabilize, I could always do it pre-discharge. I could rapid pace him, make sure the leak was minimal, and bring him back in. So that was my reasoning at that point. But 5 months later, this is his echo. And that's the beauty of the self-expanding valve. And that's why I said I'm shamelessly partial to it. Most often, there is a good difference. And I don't know if Ganesh, you and Dr. Petronio and Sushil have seen this, but 3-4 months later, the leaks are always less. I don't know if there is muck that forms in those small areas and closes it off, or it's just the valve continues to expand. But we had mined it.
I don't think this valve will expand anymore because you've really thrashed it with multiple balloons. I think what happens is, thrombus forms between the gaps, and then
I also
endothelial
think so.
forms. And the other important thing is the pressure load is significantly reduced, so the LVOT will start shrinking as well.
Absolutely.
And then you get seals forming in the subalveolar level as well. So there are a lot of things that goes ahead once you put a lot of metal, any metal in a patient. So I think, thankfully, these things do reassuringly improve. And that's been shown as well, by the way, in the US ID randomized trials as well, on a match-to-match cases. In the vast majority, so 95-98% of patients, the AR grade seen does improve by 1 grade at 1 year follow-up. So
that's, I was so, the patient kept blossoming. I would call him every week and say, "Uncle, how are you feeling?" Fantastic. The only complaint he had was that his wife could no longer keep up with him when he walked. And that was, and I
I'm
waited.
glad you stopped at the walking bit and not further.
I waited, and then at 5 months, this was the echo. It was so gratifying. So to summarize, even with the most meticulous planning, which I spend, and I want to insist on this, I spend at least 3 times the amount of time in doing the case, in planning the case. So that is what I feel defines how I approach my cases. So even with the most meticulous planning, sometimes a case will surprise you. And in TAVI, in very few situations, speed is necessary. So consult the team, take as many opinions as you want, but remember the decision and the responsibility lie with you. I have several key comments, including from my father. You will ask me what to do and then do what you want. So I always tell them, I ask you what to do because I want to know if I factored what you're thinking. Doesn't mean I have to listen to you. So the decision and the responsibility lie with you. A series of systematic steps always before thinking out of the box. And finally, knowing when to stop is the difference between life and death. Thank you all so much. The floor is open. Sushil.
No, very good.
Went through it. Very
interesting.
systematic. Yeah, sometimes there are things that will surprise you. So I think you just have to be careful and thoughtful and everything is a risk benefit.
So shall we move on to the next case?
Thanks. So let's do that.
Yep, it's already 7 o'clock and we still have 130 people. It's 7 p.m. I know. So very quickly, Dr. Ajay Swami, our dear friend from India. Ajay is from the Indian Air Force and presently stationed at the Command Hospital in Bangalore, an experienced interventional cardiologist and a keen researcher. He is also an international senior scientist fellow of the Indian Council of Medical Research, ICMR. Ajay?
Thank you, Dr. Sai. Without, first of all, lots of thanks are due to him. I don't think I deserve to be in such august company, but it's really a great pleasure. Just look at this case. This is a 72-year-old male, COPD, hypertension, diabetes, beta thaltrate, symptomatic for the last 2 months and 1 episode of syncope a week back. He had been asked to undergo surgery, but however, he refused and came back to us with another episode of syncope. He had a heart team discussion, as we always do. He had a mean gradient of 92 with a normal LV function and almost normal coronary. And one can see
Slides do you guys see the slides? I don't see them moving.
Ajay?
Okay.
Ajay, I don't see the slides
them.
moving.
Okay. Is that same now?
Yeah.
Is that
Yeah, now we see it. That's good. Okay, thank you.
okay? So you can see the echo, and you can see that it's actually bicuspid valve and calcium, and there's a lot of gradient, good amount of LV hypertrophy. And that's the gradient that we got, a mean of 91 and a peak of 156. These were the measurements that we got, very, very good femorals, and an STJ of 29 and 33, diameters of 23, 29, 26, and a perimeter, the 5 millimeter above the annulus, perimeter 79 and 8 millimeter above 78. This was the time when we used to measure multiple diameters across and then decide what valve we finally used. Now we're pretty much down to what the annulus is and then look at whether it's a funnel or a hat. And so this was actually suitable for a 29, and that's what we decided. This was a heavily calcified bicuspid valve, suitable for a 29, tortuous femorals, but very, very good size femorals. The ostia were good, the height was good, the anatomy was good. And that's what we did. This is what we normally do. Look at it from the other side before deciding where to puncture. This is for the vascular access. Examine the valve after crossing. This is our practices that we cross and then examine, since the valve is loaded outside. And we used an undersized balloon, sized to the smaller diameter. That's what we did, although we thought it was all right. But as events panned out later, we find out that it wasn't enough. And you can see that the valve looks horribly constrained. And every time we would try to partially deploy it, this happened actually twice before we showed, and it popped out. Although our initial implantation depth was all right. I don't know if it's running. Is it running?
Yes.
So with partial deployment, it popped out. So when we recaptured it and put it back in again, all these points have been discussed. You can see that it looks horribly constrained. So we heard Dr. Ganesh say that he would have shot me if he tried to do it again, but then still we went ahead. You know, we have to learn from our deployed, and you can see that it released, although it looks constrained, I released. But it popped out again. So now what do? We've got an under-expanded valve, and the frame has popped out. And the possible reasons were either an undersizing, a shallow deployment, sometimes even a deep deployment. We had one septal bulge which we missed, which caused our valve to pop out. Under expansion of the valve, which was very obvious. Possible nose cone entanglement, but if one goes back to the video, you see that the nose cone actually hasn't come out yet. There's no way that it could have got entangled when we didn't try to remove it yet. Wide LVOT. So what did we do now? So we snared and pulled it up, redilated it, and decided to put another valve. And that's what we did. This is balloon dilating it again, trying to go away from the LCC and trying to see if we can move it out. There, dilating it again. Putting in another valve, the second valve examined, positioned. And the first valve probably helped us to position it better. Although it was slightly deep when we got in after the first valve popped out, we were worried at leaving it as shallow as we did. And this is our second valve, fully deployed. And then under rapid pacing, post-dilated it well. The gradient was 28 at this time, and then it got better thereafter. We got away with a slightly deeper implant, but not much AR. And with time, at 6 months follow-up, this looked absolutely fine. As he said, probably the LVOT regressed as the gradient went away, and we ended up at 6 months with a mean gradient of 16. This wasn't ideal, but it was perfectly all right as far as we were concerned in our limited experience and our limited skills. And this is what we do with valve embolizations. I'm going to leave Dr. Ganesh to speak about it, and we won't, and the lessons learned basically in bicuspid valves, which are different animals, we needn't be absolutely perfect. The anatomy dictates the strategy, and it's important to get away alive with the best kind of result that one can get with whatever limitations are inherent in our particular system. We accept a little imperfection. This is the flaw that makes for perfection. Thank you for your attention. I know we're a little short on time, so we'll allow the experts to speak and bash us.
No, I just want to start by saying I think it's great to present these cases, and these are not meant to be things that people did wrong. I had a pop out this year, and it's not that it doesn't happen with experience. It's what we go for, and sometimes the anatomy is going to dictate the result. It's just understanding and being able to manage it, and that's a nice management of the complication. These things will happen no matter what we do, and I think the question is, my pop out in a bicuspid was a guy where I tried to implant too high, and because there's conflicting information, right? You heavy calcium, you want to land high, so you seal high. If you land too high and the forces are too great and it's self-expanding, and there's not anchoring in the aorta and the angulations are different, it may still pop out. So I don't think there's, I think it's great. And the goal of these sessions is to prevent these cases, so we learn. And even if we learn, this may still happen. So you have to learn how to manage it. The only thing question is, I missed there. How aggressive was the pre-dilatation? That's the one thing that sometimes can help, but not always.
So out of the 20 odd bicuspids that we've done, we actually tried to do pre-dilatation matched to the minor diameter, and that's what we did. And sometimes that's not enough. Actually, we had a 20 millimeter balloon for pre-dilatation, but probably our pre-dilatation wasn't enough, I feel, because the balloon was slipping a bit, and we were probably, that's why I think that was one of the reasons why our valve popped out. The rest of it, the anatomy, as you said, was a little not perfect for a valve, because there was a lot of eccentric calcium, and it was actually a true bicuspid. And we kept trying to be as shallow as possible. And we did have some experience because it popped out the first time. So we tried to put it a little deeper, but the second time it happened again. Now, suppose we had to do something different. The reason why I presented this case is I'd like to know what everybody else would do a little different to try and prevent this from happening. Because as you can imagine,
I'll let Ganesh comment. His comment earlier, when it looked that way at 80%, I would have probably done more aggressive. And in general, for bicuspids, I've been more aggressive with my pre-dilatation now if I'm using self-expanding. I think that's the one thing I would consider. I don't know what the others think.
I think.
What was exactly the diameter, the main diameter of the annulus?
I can pull up that slide, just a moment.
So while we are waiting for the slide, Ajay, just interrupt me whenever you find it. What I have learned is the best way to prevent this is to actually predict it. And my favorite kind of bicuspids are the ones where the LVOT and the annulus are parallel. And if they are a cone like this, you still can get away. But when they are like this, that's when you have the highest chance of a pop out. And what I quite like to do is I deploy the valve, I release the tension, and I let it sit there for a good amount of time to see how it's behaving. Even gently try and move the catheter gives me a good indication of how it's going to behave. But like Ganesh and Sushil said, if it's going to pop out, sometimes it still does pop out. And what really helps is actually not pulling the first valve up very high and leaving the inflow of the second valve in the outflow of the first valve. Somehow it serves two purposes. It holds that second valve from bouncing around, and I think it gives a little support to the first valve. Dr. Petronio?
So it was 23 sorry.
I was asking the diameter because sometimes with bicuspid, the pop outs and the difficulty in the complete expansion of the valve is due to the fact that sometimes we oversize the valve.
So it was 23 and 26. 23 and 29, a mean of 26. That was the 26, diameter.
But it was very heavy calcium burden, wasn't it?
Yes, that's true. That's true. Very, very heavy calcium.
So
and very
I probably would have underestimated. In this case, it's not a law. It is not a law, but we've been calculating an algorithm with the CT, and if the calcium is very high, and or there is a big RAFA with calcium, it depends on the type of bicuspid, then according to that we undersize the valve, taking 1 millimeter from the annulus main diameter.
So I can't believe it's I mean, always it's very important, like Dr. Petronio said, to look at the 5 millimeters and 4 millimeters above, see where the seal is, because bicuspids, there's a whole new chapter of leaflet seal.
Yes.
And I'm very comfortable with valves even at -1 sometimes when I'm so confident, but the key is looking at the CT yourself, and you'll almost always know if it's going to hold or it's not going to hold. What I really hate is unicuspids. What I really hate is type zeros. And what I know there's a lot of hate, but what I really hate is asymmetric calcium. Otherwise, I'm happy. But anyway, it's almost 2.5 hours since we've been here. Before we say bye and get some closing comments, I'd like to invite Dr. Teguh Santoso from Indonesia. He's one of the most prolific operators in Indonesia. We've all learned so much from him. Dr. Santoso, are you ready to say hello to us? Chandra, is he still there with us? Admin? Okay.
Dr. Sai, Dr. Ganesh was going to speak to us a little bit about valve pop-out. Maybe a couple of just 30 seconds. comments from it.
I guess
It's
the
rare to
key
get to
thing
speak to him.
is with I keep going back to this. I think when you have resheathable technology, don't be afraid to use it. I think when you deploy a valve, whether it's tricuspid, bicuspid, unicuspid, if it's not expanded more than 70%, so if your valve frame is only halfway there, take it out. Do not release it. No matter how deep you go or how shallow you go, you have no idea what it's going to do when you're going to post dilate. It could sometimes end up deeper in the left ventricle, and sometimes could end up pop out completely. So resheath it, take it out, do another pre-dilatation, either with the same balloon size, we are worried about rupture, or take one balloon size higher, because it's a lot safer doing that than doing a post-dilatation using the same balloon size, because your risk of rupture infinitely goes up when there's heavy calcification. And then as Sonia suggested, in both your pre-dilatation, in that case, there was definite indentation on the left coronary side area.
Left coronary side.
Perhaps undersizing the valve, taking 26 may actually end up giving a better result. So I think bicuspid is one area where the science is weak, and my field is a lot stronger at the moment. And I think in time, the science hopefully will get stronger, and what I do in my hands may get less. I think that's what we all aim to do. But we already have some science. I think using the CT, really, really carefully looking at the calcium is, where it's distributed, making many measurements. Bicommercial distance helps. The distance between the raphe to the opposite area helps to size your valve better. And then I think the pre-dilatation is really, really important. Really do a good pre-dilatation with angio. Sometimes actually I give contrast as well during pre-dilatation, really to see, sometimes the balloon may look fully expanded, but because you do not know in spatial orientation whether it's been pushed away, the contrast will tell you, has it been pushed away from the left coronary sinus or not? And then you can say, okay, this is going to be not a good day, and then I might take a bigger balloon. So I'll stop there.
Brilliant.
So I think we should wrap up.
Agreed.
I can't believe we still have 100 people after 2.5 hours. Thank you all for patiently being here. Thank you, Dr. Petronio. It was such a pleasure to have you with us today. We look forward to more of this. Ganesh, Sushil, I'm not going to thank both of you. And I'm going to allow, in the usual tradition, Dr. Sonia to say a few words, then Ganesh and Sushil to wrap up. That's it.
Well, first of all, I was very pleased to be able to pass these 2 hours with you. It was quite friendly, sort of talk about interesting things. There is always something that you need to learn, or anyway, to know that the other people are of the same opinion as you. And if they are not, then you can learn some new things. And well, it was very nice. Thank you.
Thank you so much. Ganesh?
Well, just very briefly, just to thank all of you for joining us. And we hope this was useful to you. We hope we've made it as clinically relevant to you as we can. Please email Sai or me or Sushil if you think we can make it better. The idea is this: we do this at least once a month or every other month, and make it clinically relevant rather than looking at multiple publications. So thank you again for joining us. See you next time.
I agree. I mean, I think the cases were great, and I think we all should learn from all the things that we've done. And I think there's always learning to happen. So thanks again for all of you for joining us, and I look forward to next month.
Absolutely. Thank you, everyone. All our friends from Indonesia, Malaysia, Singapore. Thank you all. See you all next month. Bye-bye.
Bye.
Bye-bye.
Hey, Edgar's come. Hi, Edgar. We missed you.
Great cases.
Thank you so much. Next time, we'll see you more often. Okay?
Okay. Cheers.